Welcome to your online lecture for knee pathologies. If you haven't watched the anatomy video or the history inspection palpation video, please make sure you go back and do that prior to watching this particular video. The focus on today's video will specifically be on knee pathology. So the mechanism of injury, the signs and symptoms, any differential diagnoses, and of course, special tests that can be used to rule in and or rule out the specific knee pathology that we are discussing. So again, the focus of this lecture is just knee pathologies. You have to have a really good understanding of the knee anatomy to understand the knee pathology. So make sure you've watched that knee anatomy video. Our first stop, or the first pathology that we're going to talk about is going to be an infrapatellar fat pad contusion. So what is the infrapatellar fat pad? Well, as the name implies, infra, right? It's going to live deep, right? But what is a fat pad? A fat pad is essentially a mass of fat tissue. And in this case, this mass of fat tissue is going to lie just deep to the patella, and it's located just behind the patellar ligament. And you can see that in the image in the upper right hand corner of your screen, right? You can see that it's positioned in such a way that this mass of fatty tissue is going to protect three bones essentially. It's going to protect the patella, it's going to protect that distal femur, and then last but not least, it's going to protect the proximal tibia. So we can see here how when we look at how we're created, right, and the depth of which our God goes through to make us, to put us in a position to be more protected. We know that the knee is one of the most exposed anatomical structures. So I guess why not put a fat pad there to protect these three bones from compromise, right? Now, if we think about the mechanism of injury for a fat pad contusion, there really are three different ways that it can become injured. But the most common way that you'll see it injured is in a hyperextension knee moment, right? Now, we'll get to an injury called the posterior cruciate ligament. And of course, one of the mechanisms of injury for a PCL injury is going to be hyperextension. So a lot of times we forget about the infrapatellar fat pad and we automatically focus on the PCL. So I'm encouraging you guys that if you have a hyperextension moment at the knee, then not only should we be ruling out a PCL injury, but we certainly should be looking at the fat pad anteriorly, especially if that patient isn't getting better over time with rehab, right? Other ways in which the fat pad can become injured, it can actually start, if it becomes inflamed, it can actually start to get impinged. So as you move into the later phases of knee extension, if it's inflamed, then you're going to impinge it between that femur and the tibia. And then finally, the last way that the infrapatellar fat pad can become injured is in a sport where you have lots of repetitive knee extension, right? So anytime you see a sport where your patient is falling into a lot of repetitive knee extension, and I can think of two, gymnastics is one of those, right? It's one of those sports where they're going to fall into extension a lot, and in diving. When the diver is on the board, they're forced into knee extension moments. So you'll see infrapatellar fat pad contusions or inflammations in those particular sports. In terms of signs and symptoms, I mean, it's relatively straightforward. So they're going to have pain on the anterior aspect of the knee, and that pain is going to be extremely deep, which makes it hard because we've also talked about the ACL, which will present that way. So how do we differentiate this between an ACL, right? And so one of the ways that we do that is they will have tenderness to palpation deep, and that deep tenderness to palpation will be located on either side of the patellar tendon or ligament, depending on who you ask. So I'm going to play this video for you guys so you can see kind of how you would assess a fat pad contusion in your clinical setting. So you can see that clinician is gripping both sides of the patellar ligament or tendon, depending on who you ask. And there's a little bit of pressure being applied as he moves that knee into a knee extension moment, right? And when you apply that pressure, I'm going to go back just a little bit. As you apply that pressure and extend the knee, what you are doing is essentially forcing the fat pad to be impinged within the knee joint, right? So a positive knee extension test, right, would be one in which the patient experiences pain with that knee extension moment. But the key to that test is certainly applying pressure with that thumb and index finger, right? And you guys might be saying, well, Dr. Crosby, I can't tell where his fingers are. Think joint line, and we'll do that in the lab. Okay, so we've got pain, we've got swelling within the knee joint or effusion, particularly on the sides of the patellar ligament, and that deep tenderness to palpation on either side of the patellar tendon. But notice it's not an independent palpation. Like you're not palpating the lateral side, then the medial side. It's a dual palpation because it's the dual palpation that creates the pressure and causes the pain. What we also know about this patient is they won't want to go into knee extension, right? And that makes sense because if you look here and you think about joint mechanics, which you all should know about now, as I extend that knee, remember what's happening if we're thinking back to the screw home mechanism. The femur and the tibia are going to be in close contact, right? And so as that knee moves into extension or that tibiofemoral joint moves into extension, we're going to impinge that fat pad. So they will avoid fully extending the knee joint to avoid the impinging moment and causing pain. Now this DD is new on the slide, so let me define it. It's differential diagnosis. So what other things should we be thinking about when the patient presents with signs and symptoms like these, right? So the meniscus, because what we know about meniscal injuries is that the patient will not want to go into knee extension because it will impinge the meniscus. We have also seen sometimes that the patient will report pain more distal on Gertie's tubercle, right? And so that's why we say the IT band should be ruled out. And because they want to avoid that knee extension moment, an osteochondral defect should be ruled out. I think the one that makes the most sense in terms of ruling out pathologies is a patellar tendinopathy, right? So a patellar tendinitis or a tendinosis should certainly be ruled out. Because the patient will want to avoid in-range extension, we also want to rule out a hamstring strain, because what we know about hamstring strains, right, is that if we extend the knee, we're lengthening that muscle. And so patients with hamstring strains will also try to avoid a knee extension moment. And then last but not least are the MCL and LCL because of the pain that might be present in the joint line. So we can see that as we get deeper into this class, we can't just be thinking about one injury. We have to be thinking about the multitude of injuries that might be present with the symptoms that are presenting in front of us. And then finally, we use our special test, right, to help us rule that out or in. So in this case, if we want to look at which special test we should be using to kind of help us determine if a fat pad contusion is present, it's going to be that knee extension test that we just saw on the video, right? So I'll play it for you one more time. That knee extension test. Again, making sure you're applying that downward pressure when you're having the patient or you're extending that patient's knee passively, okay? All right, the next pathology is traumatic bursitis. As the name implies, it's an inflammation of the bursa. And so let's take a look at the knee, because the knee is one of the joints in the body that has the most bursae surrounding it. Hint, hint, it's going to take a lot of contact. It's exposed the most, hence the reason it has so many bursa. In general, if we were to define what a bursa is something that is a fluid-filled sac. Its role is, again, it's like the fat pad, it's protectionary. Its major role is to prevent friction or rubbing of two anatomical structures, or to provide protection against anatomical structures that are exposed to the environment. So we have several bursa, as I've mentioned. I'll start posterior on the knee. We have this semimembranosus bursa. Its major role is to prevent friction or rubbing of the semimembranosus against the femur and the tibia. As you know, in terms of anatomical layout, the semimembranosus is closest to the femur and the tibia, and we know that there is a friction and rubbing that can occur, and so there's a bursa there to prevent that friction and rubbing. We have the pes and serine bursa. Remember, as that sartorius, gracilis, and semitendinosus come off and then have an attachment to that tibial flare, right? Because it's such a tendinous structure, as we flex and extend the knee, it can absolutely cause irritation on the tibial flare. So we have a pes and serine bursa. We have the deep infrapatellar bursa, which is different than the infrapatellar fat pad. Remember that infrapatellar fat pad's going to sit right about here. The infrapatellar bursa plays a different role. The infrapatellar bursa prevents friction of that distal patellar tendon. I'm saying tendon because we're talking about the whole structure. It prevents friction of the patellar tendon against that, what am I thinking? Tibial plateau, the most proximal portion of the tibia. Okay, guys? Then we have the superficial infrapatellar bursa. So we've got the deep. Why? Because it's deepest of the two. It's going to prevent friction of a tendon across a bone. So it's the deepest bursa. Then we have the superficial bursa, and it's superficial because it lies between the actual tendon and the skin. And its major role is to prevent irritation, friction, rubbing of the patellar tendon against the epidermal layer. Then we have the prepatellar bursa, which is the one that we'll see most often present in our clinic. The prepatellar bursa, as the name implies, sits above the patella and between the skin. So anytime we bump our knee on something, right? Anytime we have a patient landing on their knees a lot, it's this bursa that will explode, as in this picture, to protect the patella from fracturing. So to me, it's one of the most important bursa in the knee. And then last but not least, we have the suprapatellar bursa. As the name implies, it's going to prevent friction of the quadriceps tendon, see that there, against the actual femur itself. These are all of the bursa in the knee. Which ones do you need to know? You need to know suprapatellar bursa, prepatellar bursa, because those are the ones you're going to see most often present in the clinical setting. Now, the mechanism of injury for most of these bursae, I'm going to say most of the bursa on the anterior aspect of the knee, is falling on a flex knee and falling directly onto that actual patella, or it could certainly be knee-to-knee contact, right? So if I bump knees with another person, but most often in the clinical setting, it's going to be patients who are falling on their knees a lot. And I can think of one sport right now that does that. What is it? Great. I hope you all said volleyball, right? Volleyball, in particular, the libero position, falls on their knees a lot to dig. And so we'll see traumatic bursitis in those student athletes. Now, the bursa that are most prone to traumatic injury are those that are on the anterior aspect of the knee. So just keep that in mind. Signs and symptoms wise, what you'll see if the bursa truly does get inflamed is immediate observable swelling in the area of the bursa. You'll see some redness essentially, and that's most often the result of contact. The contact causes the redness, but it certainly could be as a result of the skin stretching as well. They're going to report mild pain that increases when you flex the knee. Just think, if I have a swollen knee, when I flex it, it's going to stretch that knee and cause more pain. And then you're going to see limitations in motion, in particular in knee flexion, because you're stretching that tissue. So in terms of differential diagnoses, we need to rule out the collateral ligaments, because what we know about the collateral ligaments is they'll cause swelling in the knee joint that presents similar to a bursitis. We want to rule out an osteochondral defect, and then chondromalacia patella, which we'll talk about when we get to the PFP lectures. Unfortunately, there isn't a special test for traumatic bursitis, but what I can say is your eyes and your observation are the special test, because with a traumatic bursitis, that knee is going to swell up massively, right? So the way that we kind of rule in a traumatic bursitis is by ruling out all of these other pathologies. Okay, guys? All right, so how do we treat traumatic bursitis? Because what we know about traumatic bursitis is that it comes back. Like the person who comes into you with a traumatic bursitis, most often it's going to come back because they're not quitting that sport, right? So we can treat it multiple ways. We can pad it, right? So have the patient wear knee pads. But in extreme cases of knee bursitis, like you see on this image, I do want to warn you, there is some knee draining that will happen. So please forgive me. If you don't want to watch it, just skip the slide. But essentially, we'll have to go in and the physician will have to go in and aspirate the knee joint. So it will look something like this. They're going into the knee joint and they're essentially going to start pulling out all of the fluid that's associated with the inflammatory response, right? And so they'll continue to do that. Right now, what they're doing is kind of injecting some pain medication. But let's go ahead and go here. You can see that he is removing the fluid that is associated, right, with the bursitis. And he'll continue to do this, and he'll get a lot of fluid. And the beauty of this is that once we remove the fluid, we can start moving the joint, right? Could you imagine having to flex this knee joint, right? You can't. It's almost virtually impossible because there's too much fluid in the knee. So this is the worst case scenario. We're going to have to aspirate our patients. But there are other ways that we can treat patients with traumatic bursitis, and that involves padding. It certainly could involve an ACE wrap, right? But treatment becomes extremely important because we can have someone who suffers from a chronic bursitis, which is what we don't want. So we want to manage the traumatic injury right away so we don't have to deal with a chronic injury later. All right, the anterior cruciate ligament, of course, probably gets the most notoriety in terms of knee injuries. Most often the mechanism of injury is going to be, are you ready? Some type of, it could be hyperextension of the knee, okay? But it's most often coupled with a rotational moment. So you have a rotational moment, you've got some type of hyperextension and a valgus load, right? Now, I'm not saying what order those occur in, but what I most often have seen in the clinical setting is there's a hyperextension moment that happens that forces the knee into a valgus moment with a rotational force, right? So we come down from a land, essentially. My knee can no longer handle the hyperextension moment, so I fall into a valgus load and rotation happens, right? Injury, though, itself results from a force causing some type of anterior translation of the tibia, right, relative to the femur. So either the tibia shifts anteriorly, or in some cases the femur will shift anterior, and we get a stretching of the two bundles, right? Now, we have seen cases where the ACL is injured in a contact moment, right? That makes sense. A direct blow to the knee causes an ACL injury, but there are people in your cohort who have ACL injuries that happened as a result of non-contact. In other words, there was nobody around them when they injured their ACL. They could either be going up for a layup. In football, they could be cutting. They could be coming down from a rebound. In volleyball, they could be coming down from a spike. In soccer, a change in movement. So what I'm saying to you all is that ACL injuries don't always happen. In fact, the larger percent of ACL injuries most often happen in a non-contact moment. In other words, it won't be what you're expecting as you're standing on that sideline. So again, just to recap, mechanism of injury, most often it's hyperextension coupled with a valgus and a rotational load at the knee. And if you have all of those three, I call them the trifecta. If you have all three of those, then most likely that athlete has an ACL injury. So if we look at it from an radiographic standpoint, when we have that patient going for an MRI, what we want to see, do you see this dark structure? That's our ACL, right? What we typically see in an ACL injury when we do an MRI is this, right? It's muddled. It's completely ruptured. There is no ACL ligament. It's not clear. There are no defining lines, okay? So in terms of signs and symptoms, what we typically will see is immediate pain, and they will have so much instability that they won't want to move the joint. The athlete, like the Achilles tendon, may hear or feel a pop, so it becomes a historical question that we have to ask. Go back to that history inspection palpation lecture where I talked about in the knee history taking, one of the questions that we have to ask is, did they feel a snap, pop, or a crack, right? One of the reasons we ask that is for the ACL. What we also know about the ACL is that swelling doesn't always occur. So that's one of the hardest things is in a traumatic bursitis, swelling is our special test essentially. In an ACL, we may have an athlete who ruptures their ACL and has zero swelling. What we do know is as the injury is allowed to sit, that if there's injury to that medial geniculate artery, then they'll also have some swelling that may occur. But what I'm saying to you all is don't always suspect that an ACL injury is going to present with swelling. They could or they could not. What we know is we're looking for that pop, whether or not they felt a pop, whether or not they're unwilling to move that knee joint. we also know is they're going to have pain throughout the range of motion. Most often, depending on if the femur is actually contused, they'll have pain with a knee flexion moment, and they won't want to move into knee extension either. And then they have limited flexion and extension, which is what I just said. Now, in terms of if we're doing manual muscle tasks, they're going to have weakness in the hamstring muscles. And part of that is when we put that patient in a prone position, typically what we'll see is that when we go to flex and resist the hamstrings are going to tug, and that tibia will slide, right? And so that's most of the time why they have that weakness with knee flexion. Now, in terms of special tests, we are finally in a place where we can talk sensitivity and specificity, and you will know what that means. So if I'm talking about a test that is highly specific in my eval, then I'm talking about a test that, if positive, would rule in the pathology, right? So if we're looking at Lachman's, if we're looking at anterior drawer, if these tests are positive, then I am 90% certain that the patient has an ACL injury, right? We have this new test on the market called Lely's test. Lely's test has a high sensitivity. What do we know about highly sensitive tests? If it's negative, right, then the patient doesn't have it. We're 98% sure that the patient doesn't have it with Lely's test. So let me show you what Lely's test looks like. So one hand on the gastrocs, the other hand pressing on the femur, and what do we see the foot doing in an intact ACL? It's moving, right? In an ACL that is not intact, we do the same thing, but what's not happening? The foot isn't moving, right? Because we have a disconnection between the tibia and the femur, right? Remember, the ACL connects the tibia to the femur. So if it's ruptured, we won't get foot movement when we do this test. So I'll go back one more time so you can see it. Here we go. So you see him pushing on the femur. You see the foot moving because the femur and the tibia are attached by the ACL. Cranking on it, no movement because the ACL is ruptured. So what we know about Lely's is if it's negative, they don't have it 98% of the time. We know about Lachman's and anterior drawer. If it's positive, they do. So the first test that we should do when we're ruling out things is Lely's test, right? Is Lely's test. Lely's test is positive, then we're going to move on to probably Lachman's test to confirm that for us, right? Because a positive Lachman's test would tell us that they actually have it. Hope that makes sense, guys. Okay, so in terms of rehab, I think it's important for you to understand what actually happens in an ACL reconstruction surgery. Some of you have already lived this, but let's go ahead and take a look. Essentially what we're doing is we're looking at an ACLR of a hamstring graft. So the physician is going to take the semitendinosus tendon. You'll see him grab it here. This is a pretty painful surgery. So we have the tendons of the semitendinosus. They're going to resect those, and they're going to use those tendons, right? They're going to use those tendons and create a graft. So you can see that graft being created here. And then essentially what they're going to do is then open up the knee joint and attempt to repair that ACL. So we can see, you guys, that this is a pretty invasive surgery. And so rehab is a delicate topic. So what we know about ACLRs or ACL reconstruction patients is that they typically have two options. They have an autograft option or they have an allograft option. An autograft option says we're taking something from within our patient and we're using something to repair that. Most often, the two options for an autograft surgery are going to be the hamstring and the patellar tendon. And we could argue back and forth with which one is a better graft. I happen to think, depending on the age of the patient and what outcome you want to see, helps determine which graft the physician is going to use. But then we also have an allograft. And the way I think about this is I will allow you to use my tissue. So essentially we take tissue from a cadaveric model, so a cadaver most often, and we use that tissue. What we know about what we know about allografts and the reason they're not used very often in younger patients is there's a high rate of, a high rate of tissue rejection. So in other words, the patient that we are putting the allograft in, their body just does not accept it. And so typically in younger patients, we use the autograft, we use tissue from them. And in older patients, we're talking 60 to 70, we'll use that allograft and attempt to repair it that way. So in terms of what we do for this patient, you're going to learn this in your rehab class. It's beyond the scope of the evaluation course, but your rehab program is going to focus on restoring range of motion first and foremost, in particular knee extension, right? So we're going to work on restoring knee extension, and then eventually we progress through a strengthening and balance program and get that patient ready to return to play. Now, when I first started out as a clinician, ACL rehabs took 8 months to a year for a patient to return to play. And now with advancements in the way that we rehab, advancements in surgical techniques, we've seen that we could have a patient start sport-specific stuff. I didn't say return to play, but we could have a patient start sport-specific stuff at about 2 to 3 months. Now, by sport-specific stuff, you guys, I'm not talking about a full-on practice. Jumping, loading, movements, right? They can start that earlier on because of the advancements in surgical technique, in rehab, and what we know about loading the graft early on. So encouraging for those patients who have ruptured their ACL for sure. Okay, the sister to the ACL, or the brother, is the posterior cruciate ligament, right? The mechanism of injury is most often, I'm going to say like 90% of the time, is going to be a hyperextension moment, but one in which that tibia is being driven posteriorly on the femur. Does that make sense? So not only does there have to be a hyperextension moment, because we know from the first slide that a hyperextension moment can also irritate the infrapatellar fat pad, right? There has to be a hyperextension moment, and most often there has to be like some anterior force, which is going to force the femur or the tibia posteriorly, right? Another thing that we see in PCL injuries is the foot is most often in a plantar flex moment, and the force is delivered to the PCL at the tibial tuberosity. So last but not least, what we will say is that a patient can also cause a PCL injury by this last thing, falling on a flexed knee. Does that make sense? So if I fall directly on my knee and the tibia gets forced posterior, I can also have a PCL injury. But most often it's going to be a knee extension moment with some type of force, right? We have to be careful though, because I've seen PCL injuries in volleyball a lot because they're landing directly on the tibial tuberosity and there's posterior forces being delivered there as well. So 2 mechanisms of injury for PCL injuries. In terms of signs and symptoms, the POP question becomes an important question to ask, right? They will have reduced range of motion during knee flexion, which is a little bit opposite that of the ACL. Most often they'll have weakness of the hamstring and quadriceps muscle group, so both versus one with the ACL. They're going to have pain in the popliteal fossa of the knee, so the posterior knee. And they're going to have pain when they get to terminal flexion. So look at everything is pretty much opposite of the ACL, and to me that makes the most sense, right? So these are the signs and symptoms, and then how do we rule this in, or how do we rule this out, right? So with the PCL, we have tests that are highly sensitive and we have tests that are highly specific. And so since we have highly sensitive and highly specific tests, the question becomes, what do we start with first, Dr. Cosby, right? I have awesome, highly specific, awesome, highly sensitive test. We always want to rule out pathologies first. So we are always going to start with the tests that are more highly sensitive, because those tests will help us rule out any injury that we think it is. So in this particular case, we are going to start with the posterior drawer test. Why did I choose that over the posterior sag test? Because it is more highly sensitive than the posterior sag test. And what we know is that if we have a negative posterior drawer test, then we're 89% certain that the patient doesn't have a PCL sprain. Does that make sense, you guys? So start with your highly sensitive test first, because then you don't even have to do anything else. Now, if that test is positive, right, then we have to move into our highly specific test to help us rule those in. And the test that we have that's highly specific for a PCL injury is the reverse Lockman's test, right? And if it's positive, then we're 89% certain that they actually have the injury itself, okay? Now, in terms of differential diagnoses, because the mechanism of injury can be similar to that of an ACL, you have to rule out an ACL injury. Because the knee is locked in knee extension and there's movement of the tibia, most often we'll see a posterior horn meniscal injury, so we'll need to rule out a meniscal injury. We'll have to rule out an osteochondral defect, and then, of course, we want to rule out any collateral ligamentous injuries as well. So, I have been talking a lot about the ACL and the PCL, and I've been talking about them as if they are only injured in isolation. So every test that I've talked about thus far is a test that will rule out an ACL or PCL rupture in isolation. What we know about ACL and PCL injuries is that they're so complex that it's very rare that we have an isolated ACL or PCL injury, right, in the clinical setting. And so what I'm going to say to you guys is in lab, we're going to learn special tests that assess just the one ligament, ACL or PCL, but then we also have to use clinical special tests to rule in multiple ligamentous injuries. In other words, what we know about the ACL, for example, is not only is the ACL most often injured, what we often see is a meniscal injury occurs and an MCL injury occurs, right? So there we already have 3 injuries that we have to rule out. Well, there are special tests that are designed to test all 3 of those structures at the same time while doing them, right? On the ACL side of the house, that's going to look like what's called a crossover test or the Slocum's test. And then on the PCL side of the house, we have what is called the dial test to assess multiple structures at the same time. So here, before we move on to other injuries, I want to say it's a rare concept to think that the ACL or PCL is injured in isolation. The special tests that are on those slides are for a unilateral single ligamentous injury. They are not designed to test multiple structures that may be involved. If we're going to do that, we have to use multiple ligamentous special tests or special tests that are used to design or designed to assess multiple ligaments over times. Promise I can talk, you guys. Okay, we progress to the collateral ligaments. The first collateral ligament that we'll talk about is the medial collateral ligament, and I spent a lot of time here in our anatomy class or our anatomy video. So hopefully you understand the role of the medial collateral ligament. Its major role is to prevent massive amounts of valgus loads, right? That's its major role. So the way that the MCL is most often injured is what? A valgus stress or a valgus load to the knee, right? It's always injured as a result of a tensile force. That tensile force just happens to be a valgus load at the knee. Now, with that said, we certainly could have a compressive force that injures the MCL. It's just an extremely rare case. The MCL can be injured with a valgus load, and that valgus load could be non-contact or contact, right? Most often, the non-contact form of valgus loading is associated with a rotational force being applied to the knee. So I described that somewhat in the ACL injury mechanism. So you can have contact injury or you can have a non-contact injury as well. In terms of signs and symptoms, I'll jump to this part right here and say this is probably the biggest predictor of an MCL injury, which is tendinous palpation, either in the middle portion of the MCL or at its proximal and or distal attachments, but certainly pain, right? Pain specifically to the medial aspect of the knee and some swelling in the medial joint line. The special test for an MCL injury is going to be a valgus test, and the specificity for the test isn't reported, but the sensitivity is. So this tells you this is a really good test at ruling out the pathology. The sensitivity is a 0.86, which means we're 80% certain the patient doesn't have it if we get a negative test. So I'm going to show you what a positive valgus stress test is going to look like. as you perform it, you can see that tibia opening up, right? Did you see that? We'll do it again. That was quick. The tibia opening up. See it opening up? That would be a positive valgus stress test. Okay, you guys? In terms of differential diagnoses, because we know that the deep fibers of the MCL attach to the medial meniscus, you have to rule out a meniscal injury. What we know about the hamstrings is that they're somewhat close to the MCL, so we should be ruling out a semi-tendinosis and membranosus strain. And then anytime we have a valgus load, a valgus force, we need to rule out an osteochondral defect. And what do I mean by that, you guys? I mean, is there any bony injury associated with the injury that just occurred? In terms of treatment, most MCL injuries are managed non-operatively because they have an adequate blood supply for healing. So this is a good thing, right? We have more than enough blood supply, and so it can heal itself. The only time that we typically see the MCL being repaired is if it actually is associated with a meniscal injury as well, because then we have to go in and surgically repair that meniscus, right? Okay. What we know about MCL injuries or collateral ligament injuries in general is a clustering of things. There's a clustering of tests that come along with that. So they have laxity with the valgus stress test. They have a history of trauma or a valgus load on that side. They have a history of rotational trauma. So as this checklist goes up, did they have an external force applied? Was there rotation with it? And they have positive, or they have a valgus stress test that's positive, then we would say that they probably have an MCL sprain. Again, clustering, putting together history with palpation, with special tests. When more and more of those things start to add up, essentially what I'm saying in this section is more likely the patient has the pathology that you suspect them to have. Okay, let's go ahead and talk about lateral collateral ligament. The mechanism of injury is a varus force, so it's going to be a blow to the inside of the knee. So again, very rare. What we know about the LCL is that it's going to be most vulnerable when the varus force occurs while the leg is adducted, right? So as the leg is kind of crossing the limb, right? And the tibia is medially rotated. So if we have both of these things happening with the varus force, most often it's going to get injured relatively easy. In terms of signs and symptoms, pain most often with knee flexion, moderate to mild swelling within the actual joint line itself, and tenderness to palpation at its proximal attachment, distal attachment, or somewhere within the joint line. And then here's the terrible thing about the special test is the varus stress test has a relatively low sensitivity. So if we have a negative, we're only 25% certain that the patient doesn't have it. So that doesn't help us. So again, we're going to have to go back to a clustering approach. Do they have tenderness palpation at any of their attachment sites? Was there a valgus force associated with this, right? And then also, what does the varus stress test look like? Since it has such a poor sensitivity value, it's just not something that we should rely on to help us make our clinical decisions. Okay, you guys? In terms of differential diagnoses, the meniscus for a different reason than we said on the medial collateral ligament, but because there is a varus force being applied, we can see that the posterior horn of the lateral meniscus can get injured. And believe it or not, the medial meniscus, if the varus force is great enough because of a compression injury, we have to rule out the biceps fem strain, so the lateral hamstring strain, of course, osteochondral defect, and the two other pathologies it can present like are iliotibial band and popliteus. I'm going to go back a slide for a second. Think about this. Here's the popliteal tendon, and then think that we have the IT band crossing right about here, coming down and attaching on Gerdy's tubercle. So we have these three tendons that all kind of have a sweet spot where they intersect. So it only makes sense that we have to rule out iliotibial band and popliteus. I know, sounds so strange, but certainly should be ruled out. In terms of treatment for the lateral collateral ligament, most of them can be handled or managed non-operatively. And the reality is they have really good blood supply. And so for those reasons, we allow them to heal on their own. Again, the only time really surgically intervene is if the meniscus or another ligamentous structure is involved, right? Okay, we get to meniscal tears and I get excited. I love the meniscus. The more and more I learn about it, the more and more I have a huge respect for this particular anatomical structure and all that it does within the knee joint, right? It's going to dampen the force. It's going to reduce shock. It's going to provide joint nutrition, just to name a few, right, from the anatomy video. So meniscal tears are often injured with rotation and flexion. Combination of the two, rotation and flexion of the knee. And or we could have an older patient or a patient that just continually loads that tibial femoral joint. So I'm thinking of jumping sports. If you continuously overuse and repetitively load that joint, you can cause a what is called a chronic tearing or a degenerative tearing of the meniscus. In terms of signs and symptoms, I'm not going to read this slide to you, but I'm going to tell you the two most common signs and symptoms that help differentiate a meniscal injury from the other knee injuries: locking, catching, and clicking. You will not see this most often with an ACL injury. You really won't see it with a PCL injury. Most certainly won't see it with a bursitis or a fat pad contusion. So one of my first historical questions isn't, did they feel a pop? It's, does your knee lock or catch or click when you're walking? And if the answer is yes, I'm suspecting at least this. Now we're going to get to differential diagnosis in just a second, where another injury will present this way. So sit tight. But really what we're saying is this is our differential question for this particular group. Now, the other thing that we see a lot in meniscal injuries, particularly if that injury occurs to the anterior horn or the peripheral part of the meniscus, is we'll see joint line effusion. So they'll have a specific effusion within the actual joint line itself. So let's take a look at how the meniscus is actually injured, right? There it is. Let's do it again. Hopefully they'll zoom in. I think they do. Oh man, that was so subtle. Let's do that again. You guys ready? Very subtle. Here we go. I'll mouse over it. Rotation, see it? And you're done. So subtle, you'll never see it happen most often. Athletes can typically get through it and play through it, and then they'll come to you afterwards. But again, it's that rotation and flexion moment that we see at the knee. So there are different types of tears that can occur in the meniscus. I kind of want to just show you what they are and just say you're probably going to see a tear outside of these. There certainly are more. But these are the most common meniscal tears that you'll see. You can have the vertical longitudinal tear, an oblique tear. This happens as a result of the overuse that I was talking about, a degenerative kind of fraying, I call it, and not tearing. You can have a transverse or radial tear, which is a little bit different than an oblique. See that upward kind of rotation? Here, it's kind of a straight through. And then you can have a horizontal tear where you have like a little bit of a flap. So that's why there's a dotted line. Essentially, there's a flapping. And so right here, what we see is kind of the progression. So if we allow our athletes to continue to participate with some of these tears, what are the implications for them? So if we have that vertical longitudinal tear that sits like this at first, but then we allow them to continue to participate, we can see that tear just gets larger and bigger. Now, this may or may not be able to be repaired depending on what zone it falls into. But this certainly cannot be repaired. So what we're going to have to do is cut it out. Cut this piece out, which means we have less meniscus. And now we have femur rubbing on tibia where that meniscus should have been, right? In this radial tear, if we allow that patient to continue to participate, we can imagine that femur loading and causing a spreading of the tear. And then last but not least, this horizontal, you see the flap? There it is, right? It'll progress into a full flap tear. And this is the patient that most often complains of that locking and clicking, depending on the position of the flap, right? In that moment of time. So what am I saying to you all? When a patient has a meniscal tear, yes, you see them there. They start off innocent, but over time, the more that we allow them to participate, they progress to something that is worse, right? And so then we have to do surgical intervention to either cut it out, meniscectomy, or to repair it. And that takes time away from participation. Yes. So there are implications for our clinical decision making. Now, the meniscus is my favorite injury in the knee. I guess you guys aren't surprised I have a favorite. And it's my favorite because it has so many special tests, and I love learning about special tests. But what I want you guys to keep in mind is this, that all of these special tests are not created equally. You need to allow the evidence, the specificity, and the sensitivity to drive your decision making when you're choosing a special test for the meniscus. Does that make sense, guys? Good. So if I look at this laundry list of what? Special tests, there's only one that has a reported sensitivity. So I'm going to start with joint line pain first. Is it negative? We're 83% certain that they don't have it. And then I might, for my highly specific test, which one are we going to choose? Good. Hopefully you said the Thessaly's test because it has a 90+% specificity, which means if it's positive, we're almost certain that they have a meniscal test. Like the collateral ligaments, the clustering of a test probably yields the best results. So that joint line effusion and or pain, joint line tenderness, right? McMurray's and pain with a full squat yields this right here. So 85% sensitivity. So if all of these are negative, then we're 85% certain that they don't have it. And if all of these are positive, then we're 84% certain that the patient actually has it, right? So in lab, we're going to go through like 10 meniscal tests. And you then have to decide, okay, based on the 10, what are the top 2 that I'm going to use? And you need to let sensitivity and specificity drive that, okay? All right, the popliteal cyst or the Baker cyst. See it here? Essentially, if we're thinking about what it actually is, it is fluid accumulation, most often synovial fluid within the posterior aspect of the knee joint or the popliteal fossa. Typically occurs as a result of a herniation of the connective tissue in the synovial cavity. And so then fluid is allowed to accumulate within the popliteal space. So think of it like a hernia in the abdominal region, but a hernia in the knee. Can also result as a posterior horn injury. So we have a posterior horn injury of the meniscus. That posterior horn injury causes a tear in the connective tissue, and so that fluid that's associated with that posterior horn injury will leak backwards. We also see it in an arthritic knee. Most of you aren't going into physical therapy, but if you saw a patient with a popliteal cyst in physical therapy, an older patient, most often it's because there's a herniation in that connective tissue and the swelling is driving posteriorly into the popliteal fossa. So all that to say, signs and symptoms are what we see here in this image. You're visibly going to see swelling within the popliteal fossa, and we call that a popliteal cyst. It will be palpable and squishy. They don't always have pain associated with that. So that's why it's listed, but it may or may not be tender. It really just depends. Typically, this is pretty harmless, unless, of course, it's associated with a meniscal tear and the meniscus is painful. But for the most part, a patient can participate with a popliteal cyst. The only concern is that that patient may have a limitation in knee flexion because the cyst is blocking the ability of the knee to get into a flexed position. In this bottom image, you can kind of see the synovial membrane, right? You can see how that leaks, how that can leak posterior and cause a popliteal cyst. Pretty much harmless in terms of treatment. Essentially, what we're going to do is aspirate the knee joint and then figure out what's causing it. Get images, right? If it's in meniscus injury, then we have to repair the meniscus. If it's just as a result of an arthritic knee, then certainly we'll treat that. And then if it's as a result of herniation, the physician will go in and suture that herniated space. I've mentioned osteochondritis dissecans in what seems like all of the pathologies, right? And so let's talk about osteochondritis dissecans or OCD. In terms of the MOI and the etiology, essentially what we know about osteochondritis dissecans is it is a chronic condition, most often results from avascular necrosis. So a lack of blood flow, necrosis, death of the osteochondral surface. So in other words, we have a dying away of the osteochondral surface. What might I mean by osteochondral surface? Remember, I said the femur is lined with lots of hyaline cartilage, right? So essentially, what we typically see in an osteochondral defect is some type of fracturing or irritation to the articular cartilage or the hyaline cartilage, which protects the distal femur. There are times where we also develop this and it's of an unknown cause. So what am I saying? Patients just getting older, the wear and tear of life has happened, right? But in an athlete, most often it's as a result of some traumatic loading and or injury to the distal femur. In terms of the signs and symptoms, it's gradual onset. So it typically doesn't happen right away. Most often the patient will be swollen on the knee joint after activity. And so a lot of times we'll suspect a fat pad contusion or a bursitis because it will swell up just like the two. But the biggest differential between the two that I just mentioned and an osteochondral defect is essentially the patient's going to be tender palpation over the femoral condyles. And so that's the differential. In a bursitis, most often, in a fat pad contusion, most often the condyles aren't palpable to pain. What we also know about osteochondritis dissecans is the athlete may also complain of a clicking and a catching, in particular if the piece of articular cartilage or hyaline cartilage has broken off into the joint line. So again, there's a sign and symptom that's very similar to another pathology, which is a meniscal tear. So we can have a chondral defect or an osteochondral defect. The chondral defect is what happens when there's a fracture to the articular cartilage, just the cartilage. An osteochondral defect means that the bone and the cartilage are damaged. So that fracture not only goes through the articular cartilage, but actually goes deep to the actual bone itself. So let's look at this. If I'm an osteochondral defect, here's my cartilage, ripped through that, and now I actually have damage to the bone. So in an ideal world, we'd want our patient to have a chondral fracture. We'll figure out how to facilitate healing of the hyaline cartilage. But then if they have an osteochondral defect, it's so hard to repair this or to treat this. So let's take a look. So you can see that's the hyaline cartilage right there, or articular cartilage. And so you can see the physician's trying to put it back in its space. This is femur, right? So we can see how that cartilage has broken off into the joint line. And so that's what's responsible. You got it? For doing what, you guys? Causing the locking and clicking in the knee. And then this is beautiful. This is the bone. So we've got the cartilage, we've got the actual femoral bone. We can see how thick that cartilage is on the knee, right? So what do we do to treat this? We do what are called microfractures. See how that physician is poking bones in, or holes in the femur? The goal is to cause that femur to bleed so that blood can stimulate hyaline cartilage regrowth. So you'll start to see it? You'll start to see blood coming out. And that blood, remember, if we have blood, we have red blood cells. And so then the hyaline cartilage can regenerate. So a highly invasive procedure, but certainly one that has to be done. In terms of what we do for these particular patients, most often we're going to do an MRI. And we're going to look at the joint and behavior of the joint most often. But in terms of mechanism of injury, so that should be an O, mechanism of injury, we see a lot of joint compression, so loading, coupled with a varus and a valgus force, but rotational shearing is also a cause of an osteochondral or a chondral defect. Just think as that femur is rotating over the tibia, right, that can cause irritation to the femur. So signs and symptoms of an actual fracture: pain, immediate or delayed swelling, locking and clicking is the first thing that I would ask, pain with joint compression, which we'll do in lab, and then tenderness to palpation on the femoral condyle and into the joint line. So again, what are our differentials in meniscal tear for sure and arthritis, which we can't diagnose in the clinical setting? They'll have to go for imaging most certainly. Okay. IT band friction syndrome or runner's knee is friction of the IT band as it crosses over the lateral femoral epicondyle. Now, remember we said that the IT band is both a knee flexor and a knee extender. And so that's why we can see a lot of friction happening. So most often IT band syndrome is going to be caused by the repeated rubbing back and forth of the IT band as it crosses over the epicondyle, and most often that's going to be as a result of overuse. Typically, we'll see this in our running sports most often. So in terms of signs and symptoms, the patient complains of like a sharp stabbing pain on the lateral aspect of the knee in the area of the lateral condyle and epicondyle region. And that pain is typically going to radiate distally to Gertie's tubercle, if that makes sense. They're going to be tender palpation over that lateral epicondyle. And the weird thing is most often they don't have pain with active and passive range of motion unless you apply pressure to the IT band while they are doing it, right? So if it's just knee flexion and extension, no problem. But the moment that they have pain with a compression force at the epicondyle and the extension and flexion, then you're concerned. Differential diagnosis is going to be a lateral meniscus tear, the LCL, and the Popliteus, right? Because all three of those structures run laterally, so it makes sense to rule them out. In terms of special tests, here they are. I can't find the reported sensitivity and specificity for many of these tests, but we have the Ober's test, Nobel's compression, and Renee's, and all of those. This is an assessment of the length of the IT band, and these two are an assessment of actual pain and inflammation of the IT band. In terms of treatment, the biggest thing that we see with an IT band syndrome is typically that patient presents to us with some type of biomechanical abnormality. And so we need to look at foot posturing. We need to look at glute medius to see what's driving the actual change in the way in which the IT band will run over that epicondyle. And of course, we can load them with NSAIDs. But our predisposing factors to an IT band syndrome is genu varum. What we know about genu varum is it's going to stress or stretch the IT band and cause more friction of the IT band as it passes over that femoral condyle and epicondyle. And then we know that pronated feet, leg length differences, and lateral heel strike all result in tibial internal rotation, which essentially alters the direction and the angle of pull for the IT band, which means it increases pressure at the lateral femoral epicondyle, causing more irritation, right, you guys? So we have to think about our gait assessment, our static postural assessment, all of those things, right, will help drive treating our patient, knowing our predisposing factors, and assessing those in a preemptive manner will help reduce the rate of that we see IT band syndrome, right? So in our pre-participation physical examinations, we could certainly assess many of these predisposing factors and address many of them in the clinical setting. Popliteus Tendinopathy is the last pathology that we'll talk about. Most often, Popliteus tendinitis is most often as a result of overuse. Patients who excessively pronate their feet are most predisposed to this particular condition. What we know is that it worsens when running downhill. And again, this is because that Popliteus is going to act to prevent like a posterior shifting of the tibia on the femur during mid stance. And what we know about this is running downhill places an increased demand on that popliteal tendon, right? So in terms of signs and symptoms, they're similar to IT band friction syndrome in terms of the location of the pain. But essentially, I think the biggest differential probably is going to be like where the pain is located. So it's going to be a little bit more posterior when compared to the IT band, which the pain will be directed more laterally. In terms of palpating, if you really want to get a good palpation of the popliteus, it's actually easiest when you place the foot or the knee in a figure 4 position, right? So place that foot on the opposite knee, and the popliteus will pop out at you in a figure 4 position. So if you really want to get a distinct feel for where the pain is, have that patient in a figure 4 position and palpate that popliteus. In terms of differential diagnosis, it's the same as it was for IT band syndrome. So we're going to rule out IT band syndrome, we're going to rule out LCL, and we're going to rule out meniscus, right? Because they all live right in this kind of posterior corner. And then finally, our manual muscle test is going to be tibial internal rotation, and then the screw home mechanism, right? Because the popliteus is hugely responsible for doing what? Controlling the screw home mechanism. Okay, you guys, that is the end of the lecture. I know it was long, but all of these are important for you all to know. Please watch this, rewatch it, and own it, because this is a part of knee evaluation. You have to own these pathologies. Looking forward to our next lecture.